Today I will discuss a topic, adenocarcinoma of the prostate. So, carcinoma of the prostate is the most common is an adenocarcinoma of the prostate. Beside this, there are a squamous cell carcinoma of the prostate is also there, small cell carcinoma and transitional cell carcinoma, which in the short I will discuss the others, except adenocarcinoma of the prostate I will discuss in this details. There are two important things in adenocarcinoma of the prostate. This is the most common malignant tumor in males is adenocarcinoma of the prostate. The incidence is highest in the USA. Most common cause of an adenocarcinoma of the prostate, the most common cause of bone secondaries in male carcinoma of the prostate. Most common cause of bone secondaries in male is carcinoma of the prostate, that is an adenocarcinoma of the prostate. What are the factors involved in carcinoma of the prostate? Age is usually 65 to 75 years, particularly after the age of 50, the prevalence rate is gradually increasing. Environmental factors increase incidence of carcinoma of the prostate occurs when a low incidence area to the high incidence area. If the peoples are migrated from the lower incidence to the higher incidence area, the incidence will be the high. The dietary factor, increased consumption of fat increases the risk, particularly the smoky foods, smoky meats are very susceptible for this disease. Diet which prevents or delay the prostatic carcinoma are lycopenes found in the tomato, selenium, soy product and vitamin D. These are the inhibitory factor, dietary inhibitor factor for carcinoma of the prostate. Important is an androgen which binds to the androgen receptor and expression of pro-growth and pro-survival gene. Castration, that is the removal of the testes, which is a source of androgen, and treatment with the anti-androgen decreases the regression. Different races in prostatic cancer risk among the races are observed. The family history, if there is a family history of the prostatic carcinoma, almost twofold increased risk of prostatic carcinoma. And carcinoma maybe arises by the family incidence, maybe earlier ages it arises. Hereditary factor, germline mutation of the tumor suppressor gene BRCA2 and germline mutation of the HOXB13 associated with increased risk of prostatic carcinoma. HOXB13 is an homeobox gene encoded in transcription factor that regulate prostatic development. How the prostatic carcinoma arises? There is a genetic and epigenetic phenomena by which prostatic carcinoma arises. The dietary exposure, chronic inflammation, androgen, germline MIC variant on the prostatic epithelium, which will cause the TMP-RSS ETS fusion gene, and critical telomerase shortening, hypermethylation of GS TP1 promoter, that is an epigenetic phenomena, which causes the prostatic intraepithelial neoplasia. Then there is a P27 loss, which will be transferred into a localized prostatic adenocarcinoma. Then the loss of this PT and telomerase activation, which will cause the metastatic prostatic adenocarcinoma, and metastatic to the lymph node and bone, and androgen receptor mutation, T53, retinoblastoma gene mutation, MYC amplification. These are the aggregation of castration resistance prostatic carcinoma. So, we are seeing that this from prostatic epithelium to aggressive castration resistance prostatic carcinoma, there are different genetic mutation and fusion, and there is a loss and activation of genetic and epigenetic phenomena. What is the somatic mutation of prostatic carcinoma? Here I have already discussed. What is the gross morphology of prostatic adenocarcinoma? Carcinoma prostate arises in the peripheral zone of the gland, usually in the posterior location, and make it palpable on rectal examination. In the prostate, there are the three zones: at the inner zone, in the transitional zone, and in the peripheral zone. If this inner zone or the transitional zone is susceptible for nodular hyperplasia of prostate, but the peripheral zone is very susceptible for the prostatic adenocarcinoma. So, if we do the TORP, transurethral prostatic resection, we generally remove the inner zone. So, for these symptoms, if we will do the transresectal prostatic resection, it is not that the remaining part of the prostate, which is in the peripheral zone, may be changed into the carcinoma in future. And this prostatic zone involvement of the prostatic carcinoma, we generally feel or rectum, we see by feeling the prostate is hard, the median groove is obliterated. So, the prostatic carcinoma in the peripheral zone is 70%, usually in the posterior location, and makes it palpable on rectal examination. If we cut the prostatic tumor tissue, cut tissue is gritty and firm. When the tumor is embedded in prostate, it may be more readily appreciable on palpation than visualization. Only by seeing that it is not very apparent that here is a tumor, but when you will feel it is firm or hard in consistency, and obviously on visualization there is area, especially whitish area. You see that this gross inspection, this part is more whitish and nodular, and if we will feel these things, we will feel that this is very firm and hard. What is the microscopic features of adenocarcinoma of the prostate? Most prostatic cancer are adenocarcinoma and consist of well-defined glandular pattern. So, the glands will be well-defined or ill-defined, or the glands will not be there. There is a rows and shades of the malignant cell. That is depends upon this grade of this tumor. If this is very well differentiated tumor, there you will see that the small glands are there, and the glands are very closely aggregated. Glands are with a little intervening stoma. The neoplastic glands are usually small. That benign glands, that is microacinar glands. Benign glands are of different size, and there is an infolding of the glands. There is papillary infolding inside the gland. That will not be in the malignant gland. Ganglion glands are a very well defined back-to-back arrangement at the little interfering stroma, and enfolding is not there. Contrast to the benign gland, prostatic glands are more crowded and lack branching and papillary folding, which have been discussed already. Glands are lined by a single layer of cuboidal or low columnar cells. This is important. If we will see that these prostatic glands cuboidal or columnar cells are there, and there is a papillary enfolding, and there is a basal cell here. So, the two cell layer, one is columnar or cuboidal and a basal cell layer, but in cases it is a normal. If there is a prostatic carcinoma, the glands looks like a smaller and glands are very closely aggregated with little stroma, and the glands are generally single layer, no basal layer. So, glands are lined by a single layer of cuboidal or low columnar cell. The outer basal cell, which is seen in the benign gland, absent in prostatic cancer. This is the important thing. In well differentiated tumor, it is very difficult to differentiate it from a normal gland. So, if we we will see that the glands are very closely, the cellular atypia is very less here. So, in well differentiated tumor. So, you will see that these glands are very closely aggregated, little stroma, and the glandular lining is a single layer of cells without any basal layer. Then we can think of it as a carcinoma of the prostate. This is used as a criteria to distinguish a benign from a malignant gland. Tumor cells are uniformly cuboidal to low columnar type. Cytoplasm range from pale color, pale clear, similar to the benign gland, to distinctive amphiphilic cytoplasm. So, it is clear or amphiphilic. These are very subjective. So, but the one thing is not subjective, that is the absence of the basal cell layer. Nuclei are large and may contain one or more nucleoli, which we will see this all types of the malignant cell, the larger nuclei, prominent nuclei, these are there. Mild variation in the nuclear size and shapes may seen, and pleomorphism is not marked. Mitotic figures are very uncommon. You see that the picture of this adenocarcinoma of the prostate, here the glands are very closely aggregated and the lining cells are innocuous type, but if you see in the high power of the microscopy, the lining cell is a single layer of the columnar or cuboidal cell, but no basal cell layer. What are the immunohistochemical marker for carcinoma of the prostate? Differentiation of a benign from a malignant prostatic gland is that benign glands have basal cell that are absent in cancer cells. They can be detected by using various immunological markers, namely alpha methyl acyl coenzyme A. This immunostat we do in the case of any doubt whether it is a carcinoma or not. We will do this staining. AMCAR, or in full form is alpha methyl acyl coenzyme A racemase. If it is positive, then it is a case of prostatic cancer. Most of the prostatic cancers are positive for the AMCAR. What is the prostatic intraepithelial neoplasia? Prostatic intraepithelial neoplasia consists of a benign prostatic acini lined by cytologically atypical cell with prominent nuclei. PIN is precursor of invasive carcinoma. PIN is of two types, low and high grade. Generally, we do not report this low grade PIN, but high grade PIN we have to be reported. So, here it is a precancerous condition. The glands are lined by this atypical cell, prominent nucleolus, but still some part of the remnants of the basal cell is there. So, it is not, if it is absent the basal cells, then it is more in favor of carcinoma. There is a presence of this small amount of the basal cell layers there. So, it is called this prostatic intraepithelial neoplasia, which is of two types, low grade and high grade. Generally, low grade PIN we do not report. Generally, high grade PIN we have to be report. How prostatic adenocarcinoma spread? So, if you will see that this morphology with the anatomical structure, so if the carcinoma is there, it can be go to the bladder, it can go, this tumor will go to the prostatic capsule. If you will cross the capsule, then the seminal vesicles will be affected. And if it is go to the downwards, the urethra and other structure can be affected. So, the direct spread invasion in the prostatic capsule, perineural tumor invasion both in prostate and adjacent tissue, spread to the periprostatic tissue, seminal vesicle, base of the urinary bladder. That can be the directly or local effect of this prostatic carcinoma. Lymphatic spread, first the obturator lymph node, then the iliac and para-aortic lymph node can be affected. And metastasis to the lung can be occur by the lymphatic spread through thoracic duct and through the posterior venal plexus from the to the inferior vena cava. Hematogenous spread can be occur to the bone. Mostly the skeletal system, the bone's metastasis is important, is an osteoblastic metastasis, strong point to the prostatic carcinoma. Another carcinoma, breast carcinoma, sometimes metastasis to the bone can be the osteoblastic. But important in the male patient, osteoblastic metastasis in the particular lumbosacral region, strongly suspicious of carcinoma of prostate. Bones involved in the descending order of frequency of the other bone like lumbar spine, proximal femur, pelvis, thoracic spine and rib. Massive visceral dissemination are very rare. For this reporting of the prostatic carcinoma, we use this Gleason's grading system. Previously it was a Mustafi's grading system, but that is Gleason's grading system in respect to the patient's diagnosis and the treatment. Gleason's grading system is more accepted. Most widely used microscopic grading system of adenocarcinoma of the prostate based on the degree of the glandular architecture or differentiation and the growth pattern of the tumor in relation to the stroma or relatively low magnification. So, one thing how we have to do the Gleason's grading system. Gleason's grading system is a low power magnification, not in high power magnification. We see that this in Gleason's grading system, the type of the glands and the type of the tumor cell infiltrating the stroma. What is the best prognostic predictor of carcinoma of the prostate? Grading and staging are the best prognostic predictor of carcinoma of the prostate. If it is a high grade, the prognosis is bad. If it is a high stage, prognosis is bad. Correspondingly, if it is a grading is low and staging is low, the prognosis is good. What is the architectural pattern in the Gleason's grading system? Two types of architecture. One is a primary pattern. Primary pattern is the most predominant pattern, and secondary pattern is the next predominant pattern. So, we have to see what is the predominating pattern, pattern 1, 2, 3, Whatever may be these things, primary pattern, it is a predominating pattern, and secondary pattern, it is the second most predominating pattern. So the microscopy by low power, you will see that this what is the predominating pattern, whether it is a 2, 3, 4, and what is the next predominating pattern. What is the Gleason's grading? So we will do the grading by the summation of predominating pattern. That is the Gleason score, and by scoring system we will be graded of different grade. Both the primary and secondary architectural pattern are graded from 1 to 5, 1 being the most differentiated and 5 being the undifferentiated. So grading is, one side is 1, 2, 3, 4 and 5. 1 is very well differentiated, 5 is less differentiated. 2, 3, 4 are in between. So grade 1 is an well differentiated tumor and consists of an uniform rounded neoplastic gland which form well differentiated nodule. And grade 5 consists of cord and sheets of the tumor cell infiltrating the stroma without glandular differentiation. That means in 1 the glands is like this, but in cases of 5 the tumor cells are infiltrated like in the stroma here. Glands are almost not seen, all these area are tumor in the stroma. This is 5, this is 1, and all these are in between. Other grades are in between these two. If a tumor has if there is only one grade predominating in all sites, then we have to be double the grading. What are the architectural pattern which have been already discussed? What is Gleason score or sum? It is the summation of grade, 2 grade, primary pattern and secondary pattern. The combined Gleason grade is called Gleason score or sum. It is a combination of the two, primary and secondary pattern. That is range 2, because its a minimum is 1, if it is other part is 1, so there is 2. So the score minimum is 2 and maximum is 10. Others are in between. The range is 2, which is represent the tumor uniformly composed of Gleason pattern, 1 tumor, or 10, which is represents totally undifferentiated tumor. This is not the minimum, this is not the maximum, this is minimum. Minimum Gleason score is 2, that is 1 plus 1, and is the most differentiated, while maximum score is 10, that is 5, least differentiated. What is the staging system for prostatic carcinoma? TNM is staging, that means tumor, lymph node and metastasis system, whether it is within the prostate, within the capsule, outside the prostate, periprostatic tissue involvement, pelvic valve involvement, and it is to the metastasis to the other side. According to this, TNM system has been done. What is the important stage in prostatic carcinoma? Its staging is an important for predicting the prognosis, but important in selection and appreciation for therapy. What is the clinical course of prostatic carcinoma? Early stage of the prostatic carcinoma is asymptomatic. In that stages, it is diagnosed by either rectal examination or by PSA examination. Early stage is asymptomatic. They are usually discovered during rectal examination or elevated PSA level. Advanced cases are there is a dysuria, hematuria, or frequency of urination. And in the far away from that is also the vertebral metastasis present in the low back pain and has a fatal outcome. Detection of osteoblastic metastasis by skeletal survey or radionuclide bone scanning is virtually diagnostic of prostatic carcinoma. How will proceed a diagnosis of prostatic carcinoma? First, by digital examination of the rectum, transrectal ultrasonography, other imaging modalities like modalities low density and specificity, like MRI, like CT, other modalities will do. And then you have to do the tumor marker, prostate specific antigen. Finally, we have to do the needle biopsy of the prostate per rectum and see whether this is involved by this tumor or not. Confirmed by this needle biopsy. What are the conditions where we will get the raised PSA condition? First is the carcinoma of the prostate, BPH, benign prostatic hyperplasia or nodular hyperplasia prostate, prostatitis, infarct of the prostate, instrumentation of the prostate and ejaculation. So, only rise of PSA, we cannot say that it is the carcinoma of the prostate, but generally the rise of more than the 10 nanogram per ml is very, very suspicious of prostatic carcinoma if the other condition is not there. What is prostate specific antigen? This is a tumor marker used for diagnosis and management of prostatic carcinoma. PSA is produced by prostatic epithelium. Only minute amount of prostate specific antigen comes into the circulation. Normal value is 0 to 4 nanogram per ml. Nanogram per ml is cut-off point. If it is above 10, it is very suspicious of prostatic carcinoma. Raised PSA value occur with localized as well as advanced prostatic carcinoma, but PSA value may be normal or less. Sometimes in prostatic carcinoma, PSA value can get also the normal or less. So, PSA is one of the important factors to diagnose, but it is not the 100% the raise of PSA will cause this prostatic carcinoma. PSA is organ specific, but not a cancer specific. It is not a specific for the cancer, but it is for the specific for prostate. Serial measurement of the PSA are useful in response to the therapy. Importance of PSA is to some extent by the diagnosis of the prostatic carcinoma, but the main importance is that when the patient will give the therapy, the serial estimation of PSA is important to see the response of therapy. What is PSA density? It is the ratio between serum PSA value and the value of the prostatic gland. It is a what is PSA velocity per year? What is the change of the PSA value? That is called PSA velocity. Normal is 0.7 nanogram per ml per year, distinguishing prostatic cancer and the benign lesion of the prostate. What is the prostate specific antigen? The diagnosis of prostatic cancer. It is secreted by prostatic epithelium. Its activity is 100-fold greater in prostate than in other tissues. Elevated in prostatic cancer when it is extended beyond the prostate. Not a specific, but also increases in case of liver and bone malignancy. What are the other tumor markers of the prostatic carcinoma? Prostatic cancer antigen is a monoclonal RNA overexpressed in 95% of the prostatic cancer. So, quantification of the PCTA is used as a diagnostic additional biomarker to suspect it as a prostatic cancer. because elevated prostatic cancer when the prostatic biopsy does not reveal cancer. One thing is important, beside this adenocarcinoma of the prostate, when we will give this anti-androgen therapy, sometimes this adenocarcinoma will be changed to an squamous cell carcinoma. So, you can get this squamous cell carcinoma. Sometimes when we will give the therapy, that will be a subclones of the small cell carcinoma, or a small cell carcinoma can be occur in the prostate. And also the transitional cell carcinoma, which maybe arises in the bladder, that can be infiltrated in the prostate, or sometimes this in the urinary tract, that whatever the carcinoma arises in the epithelium, that will be infiltrated in the prostatic through prostatic urethra, it will be infiltrated the bladder, and there is a bladder transitional cell carcinoma. Beside this, there are soft tissue surroundings, Cadbury sarcoma, other tumor, mesenchymal tumors can be also arises, but those are very less. Important that this prostatic carcinoma, we generally mean prostatic carcinoma means prostatic adenocarcinoma. Sometimes the prostatic duct these are this acinar carcinoma, mostly the acinar carcinoma. The ductal carcinoma is there, also occur, but this is the prognostically a bad carcinoma, ductal carcinoma of the prostate. Thank you very much. This ends this discussion of prostatic carcinoma. You read this here from book, and any difficulty or any doubt, talk with me. Thank you very much.